Hello, everybody. My name is Uwe Platzbecker from the University Hospital Leipzig in Germany, and it's my great pleasure to talk today a little bit about the scientific question which was actually given to me: when is an anti-infectious prophylaxis recommended in patients with AML? As we all know, acute myeloid leukemia is a disease which at diagnosis already presents very often with a severe deterioration of blood counts, mainly proliferative disease with leukocytosis, but at the same time, many of these patients present already with severe neutropenia, but also infectious complications like pneumonia at diagnosis. In turn, the therapy given to these patients, like intensive chemotherapy, but sometimes also less intensive, so-called hypomethylating agent-based therapy, induces or aggravates neutropenia in these patients. So patients not presenting with infectious complications at the very beginning are at an increased risk to develop bacterial or fungal infections thereafter. At this stage, it is not generally recommended to go for an antibiotic prophylaxis while therapy is given to these patients or during the surveillance. However, in some cases, especially patients with already presenting with severe neutropenia or mild to severe infectious episodes at the very beginning of the therapy, I think in our institution, we actually go for an antibiotic prophylaxis according to the guidelines, but also according to the bacterial profile and the potential site of infection in these patients. However, there are no randomized trials basically confirming a general prophylaxis with antibiotics in patients undergoing therapy. At the time of neutropenic fever, then of course in calculated antibiotic therapy, but also diagnostic approaches, including CT scan, are of course recommended. The case is a little bit different for antifungal prophylaxis because there actually is a clinical trial, randomized clinical trial, which showed superiority with regards to invasive fungal infections, but also superiority with regards to overall survival for posaconazole compared to the standard of care at this time, which was actually fluconazole and itraconazole. So therefore, at this stage, posaconazole prophylaxis is recommended in patients with AML undergoing intensive chemotherapy throughout the time period of neutropenia. I think the same is also done for patients undergoing azacitidine plus venetoclax-based therapies, because this combination is also inducing long-term neutropenia, especially during the first cycle. So therefore, I think at my institution, but also at other institutions around the world, but also in clinical trials like the VIALE-A trial, posaconazole prophylaxis was and is recommended, especially during the first cycle of an HMA-VEN-based therapy. There's an interaction with regards to the metabolism of drugs through to the modulation of liver-associated cytochromes, and therefore venetoclax is or has to be reduced to a level of less than 100 milligram daily if such a prophylaxis is actually intended and also given to the patient. This kind of interaction actually can also be seen with ivosidenib, so an IDH1 inhibitor. Therefore, also dose reduction in that case is given. So I think in general, azoles, when given especially as prophylaxis, need to be used with caution given the interaction via the cytochrome with many agents, not only leukemia agents, but also other agents like therapeutic interventions, including antibiotic, and therefore caution in this case is always warranted.